Hello out there. This is Dr. Sachin Kale. Welcome to another podcast of the KPL Weekly. Friends, has this ever happened to you? You are in your OPD. A patient comes with complaints of thyroid swelling. You evaluate the patient and you see that it's a solitary thyroid nodule, and you decide that you want to do an FNAC. So an FNAC is planned, everything is done as per protocol, and slides are referred to the laboratory, and bang comes the diagnosis, and the diagnosis is no opinion possible. Has it ever happened to you? Isn't it frustrating? Well guys, no need of any more frustration, because this time in this KPL Weekly podcast we are going to learn FNAC technique. I have called it FNAC 101, that is getting more from less, as in getting a better diagnosis from less of a material. Friends, you know that FNAC is a simple procedure, it can be accurate, it is fast, it is safe, but there are certain contraindications like anticoagulant treatment, lesions like carotid body tumor, hydatid disease and pheochromocytoma. Criticism of FNAC is that it is either sometimes false positive, which is rare because always due precautions are taken care. Then we have false negative also sometimes, and that is because of the sampling issues most of the times. And there are other issues like sample quality, sample preparation and interpretation. FNAC is of two categories, that is superficial and deep. Superficial, when it is palpable, can be done without image guidance, or sometimes image guidance can be employed to see where the needle is going. Deep seated of course needs image guidance, and it can also be done intraoperatively. What we have to take into consideration is some of the complications that can happen. Mind though, complications are very rare, but they are more common in deep seated compared to superficial FNACs. Complications in case of superficial FNACs include pain, bleeding, infection, vasovagal reaction and pneumothorax. Complications in case of deep seated FNACs include hematoma, pneumothorax, infection and tumor seeding. So these things we have to keep in mind and be aware of the issues that can rarely happen. That's why consent is necessary for FNAC procedure. Now what are the equipment that is needed for this? Remember friends, it is a fine needle aspiration, so needle has to be fine, so 22 and above, 22, 23, 25 up to 27 can be used, and syringe that is recommended by the books is 10 ml and 20 ml, but it works even with 3 ml and 5 ml syringes also. Needle holder is not mandatory, glass slides and fixatives of course is mandatory, so 95% ethanol or methanol is the fixative which is used commonly for FNAC, and of course lab would need staining reagents. So once our equipment is ready, patient has given consent, what we need to do is take the patient for FNAC and feel the lesion. If the lesion is very small, sometimes it can slip away like a small lymph node. In such cases what we can do is we can push the lesion in front of the fingers till the time it no more moves, and thus it becomes fixed. Once it becomes fixed, we can use the syringe and needle and penetrate the lesion and do our FNAC. There is one more technique of fixation also, that is in between two fingers. We can stretch the skin between the two fingers, immobilizing the swelling in between, and then do the FNAC. One more thing about thyroid FNAC is that thyroid FNAC sternomastoid muscle can come in between, but we have to see to it that our needle doesn't go through the sternomastoid muscle. If the swelling is behind sternomastoid muscle, we can use a technique like this shown over here. By pulling the sternomastoid to side and exposing the lesion, exposing the tumor, we can do FNAC. So our needles are ready, they are fine needles, our syringe, everything is ready, we have immobilized, we have seen how we can immobilize, how we can enter the lesion. Now coming to the proper technique itself. So this is the sequence of events that happens in an FNAC. In the first figure we can see the lesion with needle in situ, needle penetrating hitting the target properly. Then a negative pressure is applied to the syringe. After negative pressure, the needle is moved to and fro in the lesion. Pressure is released. Then needle and syringe is taken out of the target tissue. Needle is detached. Syringe is again filled with air, and with the help of this air, a small drop of aspirate FNAC material is expelled onto the slide. So that's the technique. So after this, there is one more technique. It is a non-aspiration technique. This was an aspiration technique. This is just needling. We are just needling the lesion. This also works well, and especially in tissues like lymph node or a solid tissue which are less vascular, this works better, because in vascular tissues, if we try to aspirate, most of the time blood comes, and once the blood comes, aspirate becomes too much to spread on a slide, leading to very messy slides, very thick slides, improperly fixed slides. And to avoid that, we can just use the needle. We can take the needle in our fingers, immobilize the lesion as shown in the previous figures, as discussed previously, and by to and fro motion of the needle, we can cut the tissue, whatever the cells that come because of the little negative pressure in the because of the capillary action and the negative pressure, it comes into the hub of the needle. So this is a very good technique to avoid hemorrhagic FNACs. So remember, FNAC, even though it is called aspiration, it is really a mini biopsy sort of. It is the cutting needle, the cutting motion, to and fro motion of the needle that leads to cutting of the tissue, and that cutting leads to the cells coming into the hub of the needle. The material that comes into the hub of the needle is a good material, but if we get too much material filling the syringe, then it becomes very difficult to manage, because the blood gets clotted in the syringe itself. But if it is a cystic lesion, then whole of the cyst, like thyroid cyst, can be aspirated, little bit of material can be sprayed on the slide, and rest of the material can be referred to the laboratory for centrifugation and preparing the centrifuged cytology smears. So two techniques we have seen: aspiration with the syringe and non-aspiration technique, that is using the needle alone. Now coming to the aspect where we have to important aspect. This is one of the most important aspects, because most of the times we get the tissue, but if it is not spread properly, then whole of the effort is like wasted. So we have to remember that we have to take a small 3 mm drop on the slide. Using the other slide, we have to put the other slide flush on the first slide, and then gently just pull the slides throughout, making a smear without crushing it and keeping the proper contact. So this is the best way to spread a smear. There are few more techniques also, like suppose if there is too much material and you see some liquid material as well as some particles on the slide, what we can do is we can take one more slide, take away the particle on that slide, and use that slide to make a fresh smear like here. On the left hand side again the same technique is shown. What is emphasized here is keeping the slide which is used for spreading flush with the original slide. If we make an angle, we can lead to damage of the cells, morphology being altered. So keeping the slide flush is important. And then if there is too much of a sort of liquid aspirate, then it can be drained off by tilting the slide to one side, and when the particles remain on one side of the one end of the slide, that can be sprayed with another spreader or spreader slide. So this is how we can do FNAC by aspiration, non-aspiration technique, and we can spread it properly. Spreading is very important. Okay, so I hope these diagrams illustrate the same things beautifully. Now coming to some of the appearances of the FNAC slides. On the top three, if you see this aspirate over here, it is a very dry aspirate containing lot of particles. So probably a lymph node or some tissue which is having lot of cell material. In the middle we can see an aspirate which is having some particles, but it is more liquid compared to first. In the third, it is a more liquid aspirate, and they have used a two-stage spreading, means they spread it little bit here and then lifted the slide and again spreaded the rest of the material. So these three are the good examples of well spread slides. On the bottom we see bad examples. On the left hand side there is a big clot of blood on the slide. This slide is broken and here these two slides are showing very scanty material and it is not well spread also. So getting the cells is one aspect, spreading it properly is the second aspect, and third most important aspect is the fixation. This is most often a confusing area. See, there are two ways in which the slides can be fixed. One is the wet fixed with alcohol, that is when the material is wet, before it dries it has to be immediately dipped into alcohol, that is for Papanicolaou staining. And second is the air dried staining. Air dried staining is used for Romanowski stains like Defquick or Leishman or Fields. So if we are air drying the slide, we have to take precaution that it is dried immediately by shaking the slides like this and blowing on it, or if you have a dryer we can use that. But if the slide is not dried immediately, then this kind of artifact happens. On the left hand side we have example of prostatic carcinoma showing well fixed, well spread smear. On the right, the damaged unfixed cells, they look like this, making the diagnosis even more difficult. So remember, if there are two ways in which the slides can be fixed, and I think if there are sufficient number of slides, one set should be wet fixed and labeled as wet fixed, and one set should be labeled as air dried. And when we say air dried, we should dry it immediately, either by blowing or using a blower or dryer. And wet fix means fixing the slide before the material gets dried, that is for Papanicolaou. Air dried is for Leishman or Jimsa. So hopefully this was a mini tutorial, sort of mini podcast, which dealt with how to get more from a FNAC material. Now what are the causes of unsatisfactory yield? Remember, we have to have the needle in the target tissue. If the needle misses the target lesion, we are not going to get any cells. If unfortunately the needle enters a hemorrhagic or a cystic area of the target lesion, then again we are going to get just fluid or blood. If there is a dominant benign lesion and beside that there is a small malignant lesion, such lesion can be missed by FNAC, leading to false negative FNAC. And sometimes, in spite the needle being at the right place, the nature of the tissue is such that it is very fibrosclerotic. Such tissues usually yield very few cells. So that is again a reason for false negative FNACs. Friends, hopefully this was a useful thing, and I would like to end this podcast by saying that good diagnosis begins with good material. So guys, this is Sachin Kale signing off the KPL Weekly Podcast. Bye, take care and happy needling.